And it's not easy because if you say it wrong, you make it sound like the pain's in their head. And that happens a lot with conventional medicine. I've had people come to me, a lot of VA patients come to me and say, oh, they think it's all in my head. I said, well, technically everything's all in your head. You hearing my voice is in your head. You seeing me in person. It's all in your brain. It's not necessarily it's not a psychological problem that you have. It's a neurological problem that you have. And it's there for a reason, but right now it's working against you, you know? So that there's a very nuance of, because that's hard education. Pain science is not a layman's topic. But if you can at least give them some power over understanding that stress is part of the water that's poured into your cup of pain that makes it overflow, then I think it takes away some of that fear of like, why do I feel like this? And why is what you're doing for that patient not working for me?
Welcome back to the 37th episode of the Build Beyond podcast. This podcast exists to challenge and guide you so that you can reach your full potential. I'm your host, Chris Netley. On this episode of the podcast, I'm excited to welcome Dr. Sarah Puente. Sarah is a chiropractor. Actually, she and I went to chiropractic school together. And after she graduated top of her class from Southern California University of Health Sciences, Sarah practiced in Phoenix and then Flagstaff before ultimately ending up in Miami, where she and her husband started their own practice that combines chiropractic care and personal training. Even more exciting than that news is the news that Sarah and her husband are about to welcome their firstborn child this fall. Sarah and I discuss parenthood. We talk about her fresh perspective on chiropractic and how she likes to practice. We also discuss the role of communication and community in healthcare. I will link all of Sarah's contact information in the description of this podcast. I have one admin note. In the editing of this episode, I lost the last 30 minutes. This should be a 90-minute episode, and unfortunately, it's only 60 minutes, so I apologize for that. It's still a great discussion, and I'm definitely going to have Sarah back on. So, without further ado, please enjoy. All right, here we go. So, first of all, congratulations on the baby. When are you due?
November.
Okay.
Yeah, so I have about Sorry, go ahead.
No, go ahead.
I was going to say I have about 3 months left. And when they first gave me my due date, it was the day before my birthday. And now they changed the due date to the day after my birthday. So Felipe is going to have a lot of planning to do in the first week of November going forward.
Yeah. Are you going to find out the sex before, or are you going to wait?
We already found out it's going to be a boy.
Oh, exciting. Is that what you wanted? Not that you probably can. I know the political and diplomatic answer is I'd be happy with anything, but
yeah, we both wanted
usually
a girl.
People have a preference.
Yeah.
Oh, really?
Nice. My cousin just had a girl and my brother just had a girl. So I think because we've had girl babies in our life, you know, they're so cute. We're like, oh, we want our own. So when we first had the ultrasound, we were both very surprised. I had the ultrasound at 11 weeks and it already looks very much like a baby at 11 weeks. Like you're like, it's like a little peanut, but it has arms and legs and everything. And as soon as we saw the ultrasound and the doctor was like, we think it's a boy, we were both like, we don't care. Like we just want a healthy baby. We want whatever that is to be ours. And so, you know, even though we were wanting a girl, we're both very still happy to have a little boy.
Our first was a boy, and then our second is a girl. And when my wife was pregnant, we found out, and we did like the gender reveal party. And she said, you know, she really wanted a girl, and she was like, but she said, I'll be happy with anything. And then I have video proof that was a lie, because when that balloon popped and pink confetti fell out, she was literally crying. And yeah. And I was like, you would not have been like, I'm sure she would have been happy, but it was definitely like a political answer yeah. But yeah, it was funny because my son was, I don't know, maybe 4 at the time. And there was another little girl there, maybe about his age. And their understanding was the baby was in the balloon. And they were going to find out if it was a boy or a girl when it fell out of the balloon. So we have video of them being my wife freaking out, super happy, crying, and these 2 little 4-year-olds just like aggressively going through confetti, looking very confused. Like, why is everyone so happy? There's no baby in here. This is very disappointing.
That's hysterical. Oh my gosh. I can only imagine their faces like, what? Yeah, that's so funny. Kids are, I think that's why I'm so excited to have a kid is when you're around someone that's, and I don't, maybe all the way up to 4, but when you're around someone that's experiencing most of the world for the first time, it really gives you
Mm-hmm.
like a renewed look at life, like the optimism and curiosity. You just don't get that. I don't care how cool your friends are, you don't get that from adults and even, adolescents and teenagers like you do from a toddler
Yeah.
when they notice a cloud for the first time or they hear an airplane or anything. And so I'm
Yeah.
I'm very excited to have that. I think at least having family members, maybe if it's not your own kid, but being around that sense of, innocence and joy and curiosity is something that I really miss now that we've moved away from my niece. So
Mm-hmm.
I'm looking forward to having it in house.
Yesterday, my 6-year-old was being difficult, and he backtalked my wife, and I got mad at him and made him go sit in the corner, and he didn't want to talk to me for a while. So my wife and him went on a walk, and she was trying to explain that I got mad because I love her, and I don't like when people talk badly to her. And he was like, "Wait, so mom, you love me, and you love my sister, and you love dad?" And he couldn't understand. He was like trying to draw the lines. And my mom was like, or my wife was like, "Yeah, just like you love dad and you love mom and you love your sister." And he was like, "But you guys love each other?" Like he understood the love individually from each of us, but he didn't connect it as like, a big circle. And my wife was like, "Yeah, you can love multiple people at one time." And he was like, "I don't know if I can do that."
Yeah.
It was just so
He's like,
funny
oh, the
because
people that
he was just
feed
trying
and
to like,
clothe. Yeah.
"Yeah, no, we're not just roommates here
Yeah.
to serve you."
Yeah.
It's funny.
That's so funny. I heard a quote, and I've used it a few times, but that love is like a candle, and a candle can light as many wicks as it needs to without losing its own flame. And I think you can use that for kindness or, whatever, but I
Mm.
think that's an important thing for maybe for husbands as much as kids, because my husband is very used to having all of my attention all the time. And so even having a cat that like takes my attention away from him, or I want to cuddle the cat instead of him, he's like, we're gonna get rid of this cat. So it'll be interesting to see him adjust when, at least for the first 2 years and more, like so much of our attention will have to be on the baby rather than on each other. So that'll be an interesting adaptation for us.
Cat's gonna be the most mad, probably.
Yeah.
She's
Yeah.
like, "Get out of here."
And she
I don't know how
has
many times.
claws.
Yeah. But your husband's gonna form a bond, the daddy daughter bond. My daughter's 2.5. No, 2.5, 18 months. So she's coming up on 2. And so now she and I are starting to have our own, like, because she doesn't need my wife for everything anymore. So she
Mm-hmm.
realizes that we can hang out and I can provide a lot of that stuff. So that bond is pretty fun.
Yeah.
Where they will start leaving you out of things at some point, which my wife is totally happy when that happens. She's like, "Fine, good, go away."
Yeah, I can breathe now. Yeah. Once you get past the
Yeah.
breastfeeding, I feel like dads get a lot more credit. That first 2 years is a little bit tough to get in on the primal necessities, but after that I think it's pretty much open game.
Yeah. Yeah, it's fun. Are you guys going to have more kids, do you think?
Yeah, we were talking about that. I actually went to, so it was very well timed. The Parker seminar here in Miami was in
Mm-hmm.
June, and Lindsay Mama was there and Lisa Goodman was there, and they both touch on, pre-peri postnatal things. Um, and one of the things they touched on was how long should you wait between your kids to make sure that your body replenishes its nutrients and that your body
Mm.
can, be a good vessel for a second baby. Because my older brother and I are 1 year, 1 month, and 1 week apart. So we're
Mm.
like 13 months and a week apart. That was back when the rumor that while you were breastfeeding, you couldn't get pregnant. And that's not
Yeah.
true. So we were back to back. And my mom was fine, and my brother and seem mostly fine. I don't know. From the outside looking in, maybe we have some deficiencies. Um, but we were thinking of just going back to back because I'll be 35 in November and we're not getting any younger and we figure we'll already have all the baby stuff, rather than sell it and buy it again. So we want to have at least a second one. And if we don't have a girl the second time, then we'll have to face a tough decision on how many we're going to have.
Yeah. Well, that's fun. It's exciting.
Yeah.
What made you make the trip to Miami? Because you were California, was it Flagstaff? You're in Arizona, right? And then Miami?
Yeah. So after I graduated, I moved to Phoenix, Arizona, and I practiced there
Okay, Phoenix.
for just over a year, about a year and a half. Um, and we had family in Flagstaff and we loved it. And anybody who lives in Phoenix knows that Flagstaff is like the getaway when it's 125 degrees because it's a mountain
Yeah.
town. It's about 6,000 feet of elevation. It's more like Colorado than what most people think of Arizona as being. And my aunt, uncle, and cousin lived there, and we were very close with them. Are very close with them. So we were up there as often as we could be. Even during chiropractic school, when we'd have our 2 weeks off, we were always driving to Flagstaff to be with them and see them. So we already knew we loved Flagstaff, but it's a small town. It's probably 75,000 people. So the job market was seemed a little bit more scarce. Um, but through a strange course of events, I ended up in Flagstaff looking at a practice that was being sold because the doctor had passed away very suddenly, unfortunately. And while we were up there, I had ended up calling a real estate agent saying, "Oh, I'm a chiropractor. I was looking at this doctor's practice, but now I saw this space and I'm curious about maybe starting my own practice." And she was a patient of another chiropractor there who mentioned, oh, there was a young female chiropractor looking at Dr. So and so's practice. And, she seemed open to being an associate as well, because I talked to the real estate agent for a decent amount of time. And so she gave him my information and he emailed me and offered an interview. And I ended up going up and interviewing with him. And of all my jobs since graduating, that was the best place that I've worked. I loved working for him. I ended up working for him for 2 years. But like every story, it kind of reached a point where it was like, if I'm ever going to own my own practice and open my own practice, I'm going to have to make the jump from this very comfortable place and start, earning my own money. So that's kind of what prompted us to do a market analysis and decide, well, are we going to stay here? Are we going to go back to Phoenix? Or are we going to move back to Miami? Because Felipe's family is close to here and we love the beach. At heart, we're beach bums. We tried to be mountain people, but snow 6 months of the year was not for us. So we ended up moving back in November, and then we just officially opened the practice in May.
Okay. And it's both of you, right? So you've got fitness and chiropractic going out of the same space.
Yeah, and Felipe is going to also do chiropractic assistant work. So he'll do muscle work
Cool.
and stretching. And then he is I shouldn't say most. I've seen that a lot of personal trainers have a lot of education and movement that would make them suited to help someone with an injury as long as they have kind of gone down that rabbit hole, I'll say. So he probably could put
Yeah.
programs together that would help people, but for the sake of our practice, I'll be overseeing the rehab portion. And the ideal plan is that people would progress through rehab to where they're not having pain and they can perform activities of daily life. And then they could become a personal training client to continue progression. So that's kind of like our idea of going from the pain to the wellness.
Yeah, that's a nice transition because they'll already have developed that relationship with both of you. And then it'll be easy. The continuity will be easier, I guess, because you both know the patient. So
Yeah.
it'll be easier to make like a really good fitness plan for their goals because they went through the healthcare process first.
And I think so many people, they suffer an injury or they have an injury that they blame on old sports or old. I mean, I don't know if you have this where you have 50-year-old people who come in and they're like, my neck's messed up from high school football. And you're like, oh, when did the pain start? They're like, last month. But I'm sure that's what it's from, and you're like,
Yeah.
I'm not sure. Might be
Yeah.
because you stopped playing football now you're having pain. But if you can progress them through passive, then some active, then active care, the likelihood that they trust you when you say this level of discomfort that you're having after your workout is okay and you can work through it, which I think your last podcast was hitting on quite a bit, right? On soreness and like what you can work through and what you shouldn't work through. I think if you have a doctor saying, yeah, this is okay, they're more likely to continue on the path to wellness versus stopping their workout, shutting down, trying to rest it off for 2 weeks. And that's what we're really trying to avoid is the failed rest for 2 weeks and then it becomes chronic pain after it doesn't go away from resting for 3 months kind of thing.
Yeah, I feel like that's a big part of at least it's a big part of what I do is basically just like giving someone a license to move again, telling them it's okay, because they got probably some well-meaning advice at some point in their life and it just stuck with them, and the back pain when it hurts to pick things up, for example, but they never deadlift because they can't deadlift because someone told them they had a disc problem 20 years ago. But they don't understand, it's probably healed. You probably could have lifted with the disc problem anyway. It probably would have been good for you. You know what I mean? They've just avoided it for so long. So it's sometimes, I feel like people come in with this in their mind, this really complicated issue, and it gets resolved within a few sessions. And it would be really nice to have a personal trainer, like a really good fitness professional right there and be like, yep, and here you go. You know what I mean? Like this is the next step.
Yeah.
You don't need healthcare. But that's why I think it sounds pretty cool what you guys have set up, because someone could just stick with you. You know what I mean? They get,
Oh yeah.
and then if they ever have another issue, it's just like you've got a doctor right there. And then, do you guys have a good network with other providers yet in Miami as far as like co-managing?
We're building it. And that's, I would say that's been a little bit difficult in the area that we're in. My last mentor, one of his big things was like, oh, like you are a quarterback for care. You should be referring up. If you're not referring to pain management or an orthopedic doctor or a neurologist, most of that you can handle in the office. Whereas before I got pregnant, I was the type of doctor who would refer out for physical therapy if I thought pelvic floor issue, or I don't do a lot of like vertigo and vertebrobasilar kind of stuff in my office. It's stuff that I would like to get into eventually, but I think you run the risk of becoming a master of none. So I have these things that I really like to work on, and they are very musculoskeletal, mechanical, functional. I love to work on shoulders. I love to work on hips. Of course, neck and back is kind of what most people think of when they think of a chiropractor. But, even headaches, if I don't think it's coming from your neck, I'm a little hesitant, neck or jaw, I'm a little hesitant to run with it. I'm more likely to refer out. So I really want to get couple good neurologists, a couple good pain management, a couple good orthopedic doctors. But around me, a lot of it is medical centers. And so I feel sort of like there's a bigger barrier for me reaching out and saying, hey, I'm a chiropractor. Like, can I meet with your doctor? Because it's not like in a private practice where I can actually go and say, you're the office manager, you have a direct connection to this doctor, you talk to them every day. It's more spread out, more compartmentalized. And I was spoiled in Flagstaff for that because I had 2 orthopedic doctors at 2 different places that I was very regularly referring back and forth with. And if I needed to send someone to them, I could text them and say, hey, sending you an urgent patient, get them in by the end of the week. Or, hey, sending you a patient, I ordered an MRI, schedule them when you can, and then they would message me back, hey, yes, we got your referral, we'll get them in. Or, hey, yes, if the patient's okay, give me their number, I'll have my office manager call them. And it was so nice because by the end of the day, I knew that my patient was going to be taken care of. We're at a medical center. If you're faxing a referral letter and then having to call the receptionist who's handling 6 doctors, it's like you might find out in a couple days if you're lucky.
Yeah. Miami, such a cool area. I would imagine that there are smaller practices though, like concierge type, maybe like med spa type things. I don't know. I've been to Miami once. And all I remember was the food was amazing.
Amazing.
But
did you go to the beach?
Yeah, it's like, well, actually it was last spring. My wife had a work conference, so we went out the weekend before and I stayed 2 nights and then flew home. And all we did was drink on the beach and go out to amazing restaurants. So
yeah, it
was like
amazing.
Drink
the
on the beach,
and
take
the culture.
a nap.
Yeah.
Yeah, and then go eat a 3-hour dinner and then fall asleep.
Mm-hmm.
But
yeah,
it
and
was fun.
I think you're right. I think that finding the right avenue for those private practices. For example, I did just meet one of the sort of representatives or the I want to say like chief executive officer for a health advisory company that does concierge medicine, and they kind of put together. They do functional testing and preventative testing more than what conventional medicine would do. And then based on your testing and your needs, they curate your providers for you. And so I think that's a really cool concept because it's not just a functional medicine provider. It's a functional medicine provider and all of the specialists that have different areas that you might need to have addressed. So I'm really hoping that relationship works out and takes off, because I think that would be a really great. I think I would fit well into that kind of model. But when we talk about concierge care here, we're also talking about a very specific tax bracket. So there's some pros and cons because you limit, you kind of limit who is willing to spend the time and resources to see you.
That's an interesting topic though, because you think about value versus cost. And I think that's the hard part about communicating with people. But when people realize that, this care that's being presented to me seems expensive, but the value is so high and the potential to get what I want is so high that, if I pay the money and I go through the care and I get what I want, would I have buyer's remorse on the back end? And I think I have been surprised. A lot of people who initially have price objections to paying cash and spending money outside of a big healthcare system, that once they see the value and they start to experience that they actually prefer it, for at least for specialty care. And I think that's the hard part about communicating to people, and that's a lot of what I talk to other healthcare providers about on the podcast, or I try to get information, because everyone has a unique way of communicating value. And I think the communication piece, at least from every healthcare provider that I've ever met, none of us are good at it, unless some people are maybe like intuitively better communicators. But it's not really something we were in different classes, but I remember we had one thing on communication where we had to stand up in front of class and introduce ourselves and shake someone's hand. And that was basically our communication teaching. But it was important because were a lot of people who were really bad at it, couldn't walk up in front of 20 people and be like, "Hi, my name's Chris. Nice to meet you.
Oh,
I'll
yeah.
be your doctor." You know what I mean? Something like, and smile and say that. People would just like freeze. And I
Or
was
say
like, oh,
a whole
man,
lot.
Yep. And I think grad school, the time is so limited because there's so much you have to cram in. But the communication piece, I feel like if you could find a way to blend that in from an outcome standpoint, it'd probably be more important than the hands-on stuff. And I think within our profession, that statement I just made, it's probably kind of controversial, but I would, if I would, at some point, if I'm looking to hire someone, I will hire a good communicator with bad hands over someone with great hands who's a poor communicator, just because those skills are so much more valuable.
And harder to teach.
Oh, yeah.
Yeah, I think that's part of the difficulty. In grad school, I think that's part of the difficulty is a lot of us are already at least semi-formed adults by that time. And it's hard to change the way someone carries themselves by the time you're in your mid-20s. We had young people in my class, but I was almost 30 already when I started grad school. And some people are more flexible into older age than others, but by the time you're 30, you'd sort of hope that you have a sense of self, and it's hard to change that sense of self or introduce other strengths or characteristics. But I agree, and it circles back to what you said, that a lot of our job is reassuring or reinforcing messaging to patients that they're not broken and that they can recover and that they aren't just their diagnosis or their image, their imaging, like their MRI or their X-ray. And if you can get that across, it has huge studied and shown benefits. When I was in school, I was part of a research project that was measuring satisfaction and beliefs in chiropractic patients versus patients who received opioid analgesic therapy. And the background work on that was difficult because it's the internal validity of the research that I did on the background was not all chiropractic or medication. A lot of it had to do with surgery. And they found that patients who trusted their surgeon or felt good rapport with their surgeon had better outcomes than other patients, even if their diagnosis, their severity, and their procedure was exactly the same. And they found similar findings. People who trusted in their therapy, who said, we're confident in their treatment plan, which probably circles back to trusting their provider. They also had better outcomes, even if the treatment was the exact same for the same diagnosis and the same. I don't know exactly how they measured level of severity other than questionnaires, but that's pretty much the objective way to do it. And that stuck in my head that if I don't have good rapport with someone, shoving a treatment plan down their throat, even if it's worked for 100 other patients, might not be as good as referring them to even another chiropractor that they may trust more or have more rapport with for whatever reason. And I think that that's something that is totally lost in the medical field because we do have to keep the doors open, right? You want to get patients in and you want to keep them coming and you want to make sure that they're, paying their bills. But I think that that's a piece of research or a part of education that we don't really talk about in school either, even though someone is obviously studying it.
There is one subsection, I think, of healthcare that does really well, and it's the mental health community. I've had the benefit of working in an integrated setting with a lot of mental health providers. And it dawned on me really quickly that, if I have someone who's not sticking with the plan, my knee-jerk reaction is to be like, well, they're non-compliant. They don't want to get better. And you'll just never hear that from a good mental health provider, because then it's like, well, I haven't communicated. Like, I, as the provider, have to find a way to communicate better with this person because they book the appointment. They want to get better.
Mm-hmm.
So it's my job to figure that out and help them. And I think that whatever secret sauce they've got going on in the mental health training programs for counselors and shrinks and whoever's talking to people, I wish we had more of that in other professions, because there's a way to deliver information and have someone actually take it in and then want to take action on that information. And then there's a way not to do it, and telling someone, here's a pamphlet, here's what you need to do, this is your prescription, if you don't do it, you're not going to get better. Making those decisions for them, even if it is a great path, you're not going to get as good a compliance. But if you have a roundabout way of communicating and the patient feels like they're part of that decision and they're along for the ride, and they're making those decisions step by step with you, you may end up with the same plan, or just they're excited about it, and you get better compliance out of it. And it has nothing to do with my ability to diagnose or to come up with a rehab plan or come up with a treatment plan. It's 100% communication. And those are just skills that I don't intuitively have. We didn't learn in school. I was fortunate enough to watch people succeed at it and then ask them, what are you doing? Like, how do you get people, who have an eating disorder to make these choices? And there's just a lot of resources out there. So it's a lot of extra reading and different things. And motivational interviewing for me has been huge. I've really benefited from that. And I'm still,
seek the extra.
I'm terrible at it, but significantly better. Just by trying to practice it, and it works so well. And I wish we had more of that in school. But it's something I've always appreciated about you, even though we weren't in the same class. I obviously got to know you, and you were an above average communicator. I think that's like, when you talk to someone and you're like, oh, this is a pleasant person who actively listens and then participates in conversations. And that may sound silly, but how much of that doesn't happen in a healthcare setting? I'm sure your patients appreciate that, when you're not just waiting to give them some cookie cutter plan. They're actually listening and then thinking, okay, well, based on what this person just said, what are we going to do? And I think that's kind of rare. I think it's a gap that we definitely have that problem in chiropractic. And I don't want to talk trash about other professions, but just as a patient going to other providers, I feel that, and now I'm a little bit more aware of it, that, I think it's just a problem across the board that we just don't spend a lot of time in learning those things.
Have you had that experience when you ask your patients about other care that they've received, and you ask them a question and then you can see it register in their mind, like, oh, why didn't I ask that question to the provider? And we take for granted as healthcare providers the things that we should know. So a simple example, a patient I had today had a hysterectomy and had to wear a binder for the surgery. And I said, how long are you supposed to wear that? And she's like, honestly, they didn't tell me how long I should wear it. And it's like, well, that seems like an important piece of advice, seems like something important. If they give you medical equipment, how long you should wear it. I have another guy I work a second job right now to, pay the bills while the practice builds. and he's been wearing braces for like 3 months. I'm like, how long were you supposed to wear those? And he's like, I don't know. I think until they stop hurting. And I'm like, oh, okay. I'm not a doctor here, so I'm not gonna say my piece, but if they asked, I would tell them it might not stop hurting if you don't stop wearing the braces and get mobility back, because 3 months is a long time for a sprain to not start to heal. And even
Yeah.
with family members will tell me, oh, I had to go and do this and I did that. And for just an example, a friend of a child of mine had some issues and had to go get an x-ray. And I said, well, what did the x-ray show? And they said, nothing. And I said, great. Okay. Did they tell you that they should avoid any kind of activity? And the mom is like, honestly, I didn't ask. I'm like, did they tell you should be doing any kind of activity? I didn't even ask. I said, well, what did they tell you? And she's like, in this moment, it feels like they told me nothing, and we take that for granted that as providers, we would be asking those questions because we inherently want to know, and we have this thought in our mind, okay, well, provocative, palliative, you have the history in your head, but patients don't have a history in their head. They don't know what history taking is like. And
Yeah.
so they don't know what a delivery of findings is supposed to sound like. They just kind of hope they don't get bad news or get sent somewhere else. And so I think you're exactly right that motivational interviewing, not just to be able to tell a patient or have a patient buy in, but also for us to have confidence and have sort of a checklist in our minds and not be so nervous when we talk to somebody, to actually relay these things that patients should know when they walk out the door. And that's where maybe the
Yeah.
brochures might come in handy, because everyone's kind of excited in an interaction, and you walk out and you forget everything you were told, but then you have something you can read. And I use Chiro Up for that. I use the condition report and
Mm,
I love it. I would recommend it
okay.
1,000 times. But I probably overshare to my patients, and that's why it's so important for me to put something in writing.
Yeah. I follow up with a report of findings after every visit because I'll just tell them like halfway through, like, I'm going to throw a lot of stuff at you. Just if it sticks, it sticks. If it doesn't, it doesn't. I'm going to put all this in writing in bullet points so
Hmm.
you don't have to think about it. And then I make YouTube videos for a lot of stuff. But yeah, because there's a lot of information. And I think I also have gotten progressively better at filtering it and just being like, is this likely to make a change? I mean, I'm going to put it in the notes, but is it going to change their behavior, or are they ready to hear this now? Should I just wait one more visit
Hmm.
and then go over this? It's not really urgent, where I think
Sprinkle it in.
we want to get it all out so they have all the information, but it can be overkill. Or just, I write a lot of referral letters that helped me get my thoughts kind of together. So for new patients, I write a letter. I get their primary care physician information, and I write a letter to every primary care physician about the first interaction. And that helps me get my thoughts together. So then sometimes patients will ask, later, well, and I'll just give them the letter, this is what I wrote. And so that you can see what I was thinking. So I try and put all of that in writing and then have it available for when people are ready to hear different things. And I'm not sure if that's the best way, but I definitely started off by just spewing out way too much information. And
Hmm.
it's well-meaning, but I think that might happen sometimes when I ask patients, well, what did they say? And what did they say? I'm like, I don't know. And in my mind, I'm like, they probably did say it, but they probably said 80 things. And
Hmm.
so I think more than likely that's what happens is it's just information overkill for a lot of people. But
Oh, yeah.
the yeah, but I don't think there's necessarily a wrong way to do it as long as you're getting the outcomes. I think that's the biggest problem, is that people will either be not saying enough or saying too much, and they never realize it, so they never try something different or make a shift.
Right. Reel
And
it
that was
in
something that
or.
was really depressing for me. Yeah, starting off as an associate, a couple different places, is like, oh, why do we do it this way? Like, it's just the way we've always done it. It's the way my mentor taught me to do it. You know what I mean? Things like that where like, well, that was like 20 years ago. Like you haven't thought about the way we're going to, like you haven't updated this in that long. And a lot of people, you know, you just get busy and you just don't make those changes. And
You get
back to the
bogged down
communication
with
piece.
billing insurance.
Yeah, it's the worst. Do you take insurance?
No. So we'll do personal injury. And here in Florida, we have something called personal injury protection that's required for all drivers that have insurance. And so you can bill PIP directly. There's steps to go through it and make sure that you do the right thing. So I'll have insurance capability on my EMR for that. And then I will provide a super bill for people with PPO or out of network insurance. So that's an offering, but out of network insurance, the deductible is usually so high that they sort of end up being cash patients anyway. And then I'm thinking about, I want to try to get in with VA. I treated VA patients in Arizona and I loved it. But there's a process for that as well, and I need to learn the process in Florida because like Medicare, there's different carriers for different regions.
Yeah, insurance is tough. I don't take insurance. I'm an out of network, so I'll do the super bill thing. Which actually in Michigan, if my patients get a referral letter from a primary care physician, getting them getting reimbursed, like the likelihood goes way up for us.
Oh, that's good to know.
So even with major insurance carriers, yeah. So I've had success as long as the primary care provider is on board, and the patient follows through with it. I just create a super bill and put all the little codes on it that I know they want, and I've had some patients be pretty successful with that, which they're excited about, and it's kind of nice. It's a little bit extra work for me, but once you get the process down, it doesn't seem to be that hard.
And if your EMR is insurance friendly, sometimes it can be easier, especially if they're on a treatment plan for something. Because if you can carry over diagnosis codes, it's pretty easy to change your treatment codes as they progress.
Yeah.
I've used what EMR system do you use?
Jane.
I use Jane as well. Yeah. I've used Chiro Touch in the past, and I like the newest version of it a lot. And then do you use something to send exercises to patients?
I am on the verge of doing the PhysiTrack app. What I do now is I just have a ton of YouTube videos for everything that I like. And some of them I have kind of built in. But basically, I have a section at the bottom of the SOAP notes where I just write out the plan and I put YouTube videos in. And then I have another form that's like a follow-up form that I put into Jane. I just copy and paste it in there and then share it with them.
Oh, okay.
So they're always just logging back into Jane to see that stuff. So then I can pass, if I say something inadvertently about their diagnosis or whatever, it's all HIPAA compliant. But I kind of want to do the app. I just haven't pulled the trigger on learning something new.
Yeah.
How do you do it?
I use Jane, but then I use Chiro Up to send exercises. So I actually do my intake forms and my exercise plans through Chiro Up, and that provides you can download it as an app. I think it's called healthco.com or something like that. And for each patient and for each condition, I have an exercise profile, and I can change it live for them. I can move exercises from their upcoming exercise to their current and vice versa if I need to progress or regress them. And I like it. I will say that and you can upload your own videos into Chiro Up as well. So I've done that because I have some favorites that I always use. But prior to using Chiro Up, when I was in Flagstaff, I used the Prehab Guys exercise library where you can create programs as well. And you can create, you can template a program. So I had, hip mobility stretches, neck stretches that I would start people with. And then I had like hip strength and coordination and shoulder strength and coordination that I would
Yeah.
progress. So that was very easy for me to use. And you can customize it for the patient by kind of like a copy paste, and then you can customize if you need to.
Hmm.
And I loved that. I really like I like the prehab guys in general. I follow them on social media, and I just like their stuff.
Yeah.
But they didn't have the practice development component that Chiro Up has. So if I have someone
Hmm.
that I'm thinking I'm between some differential diagnoses, I'm not quite sure, I don't know, they have like a mix of symptoms. You can go in and they have like an evaluation section where I can type in the diagnosis, and then I can look at what they have seen the research say about specificity and sensitivity of certain orthopedic tests, and which tests should be positive and which tests should be negative for specific conditions. And some of the conditions are very built out because there must be a lot of research on them. And then some of them are a little bit more sparse on information, but I really like that component because I think as healthcare providers, it's just not realistic to think that we're going to remember everything that we've ever learned every time we see a patient when we're not treating it every day. And when I was in
Yeah.
school, I was just sure I was always going to be able to draw the brachial plexus and the lumbar. I was just sure I would never forget
Yeah.
all my clin lab, measurements and the different types of anemias and all that. And of course, 5 years into practice, I'm like having to look at my notes, and it's been humbling, but
Yeah.
also good because that challenge makes you, I think, empathetic to other healthcare providers as well.
Yeah. I don't know how like primary care physicians and people who work in a hospital, the amount of knowledge that they have to carry around just, and make those decisions. It's pretty crazy. Nurses as well. It's just, we get to be experts about, like this much, and
Mm-hmm.
experts within like even a subsect where we only do conservative care. I don't have to know anything about surgery or injections. Just know
Oh,
enough to refer.
pharmacology.
Yeah.
Every year, 100 new medications come out. I can't even imagine. But there is an app called Up to Date, and I think it's kind
Hmm.
of like the Chiro Up is like our Up to Date, where you can go on and quickly
Okay.
sift through and quickly look at things. I don't know if it gives diagnostic information like Chiro Up does, but I've heard so many providers reference it, and I think it's probably
Yeah.
great because it probably cuts down on mistakes.
Yeah. That's a good idea. Yeah. I just Google everything or chat
Yeah,
GPT at this point, and I get
my
a
husband
lot of
loves
good information
ChatGPT.
pretty quickly.
Yeah,
It
I'm scared of
definitely, I think
AI.
there's going to be, yeah, it's addicting though, because when you create an account, it starts to know you. So it starts to spit out better information because it knows what you want. So I try
Scary.
not to use it for creative stuff, because I like to, if I'm going to write something, I write it, but I'll definitely ask ChatGPT for topics. What would,
Hmm.
I'm trying to connect with a certain type of patient. What are some topics that would, you know what I mean? And then I can make my own creative content based on those topics, but it's very helpful.
Yeah, it makes everything quicker. It would be nice, and this is a
And it
question
cuts
I
down
should
on all
have.
like the, go ahead.
I should have put into ChatGPT is it giving a easy layman's description of an explanation of benefits for insurance.
Yeah. Yeah, it's helpful. But that's a funny thing too, is I think patients are doing that a lot now too. And so they're, some people are much more well informed than what you would expect when they come in, because they ask Chat GPT. It's like, oh,
Yeah.
a lot of what I'm going to tell you anyway. But I think they lose the context of it. So it's anyone could go read a research paper, but could you understand how to apply that? I think that's maybe where the AI isn't there yet. And I think even a lot of healthcare providers struggle with that. How do you take research and knowledge and make it actually functional?
Mm-hmm.
But that's, I think, the art
Actionable.
of healthcare. Yeah. So do you have a favorite type of patient? Who do you love to work with?
It's kind of I would say that's a tough question because I love to work with athletes, but I
Mm-hmm.
I love just as much to work with somebody who has never worked out before but is very motivated to do so. And I think that comes from a lot of the feedback that I've gotten from patients in various points of my practice because I've had patients come in and they're terrified. They have no idea what's wrong with them or why they have pain or why they've started having it. And just circling all the way back to motivational interviewing and practicing lifestyle medicine, not just physical medicine, you'll ask people, well, what do you do on a daily basis? And they'll say, well, I sit at a computer for 8 hours and I commute 40 minutes to and from work. And it's like, okay, so we now know that 9.5 hours of the day you're sitting. What do you do when you get home? Well, I watch TV and I eat, and okay, are you doing that sitting? Okay. So maybe 12 hours of the day you're sitting. And then, how do you sleep? Well, I usually watch social media in bed before I go to sleep, and I kind of sit up and before I go to bed and I do that for like an hour. And it's like, okay, so now we're up to 13 hours of sitting and probably poor sleep. And it's like, it may not be the whole reason that you're in pain, but if you had told me that you were drinking 80 ounces a day, exercising for an hour a day, stretching, making sure that you take work breaks, meditating, if you had told me you were doing all of those things and you were in pain, then I would be as worried as you are. But because of this history that you've given me, I'm not that worried because we have a lot of things we can work on before we run out of targets for therapy. And that's usually the phrase I'll use. This may not be why you're in pain, but we have targets for therapy right now, and we can deplete your conservative options. And that goes all the way back to Scott Halderman interview that I did at SCU, and he was talking about the Commission on Bone and Joint from 2010, where they estimated that
Mm-hmm.
90%. I don't remember if it was all spinal pain or if it was just back pain, but 90% of pain will never get a specific diagnosis. They'll never be able to tie it to an objective thing that's wrong with you. And you see it all over. And this is a great thing about social media is that providers are able to educate, but a huge percentage of patients with disc injuries don't have pain. A huge percentage of patients with arthritis don't have pain. So can we point to those things? Well, these things are targets for therapy, but are they definitively what's causing your pain? Science would say we're not really sure, right? Or at least past research would say we're not really sure. And so that I like that patient. I like that patient that has a lot of work to do and some low-hanging fruit because I think it's relatively easy to look pretty good as a provider if you just kind of care about what they're doing during the day.
Well, you get the best results with low hanging fruit because it's simple. It's easy for the patient to do. It's easy for them to see and conceptualize and understand, and then the gains are so huge. It's like when someone starts fitness and they haven't been doing fitness, they get strong really fast
Those
because they're starting
neurological
from nothing. You know what I
changes.
mean? They're
Yeah.
Yeah, and that's super exciting for someone to see that progress. And so I
Oh,
think
yeah.
that's I, I love that perspective of yours because I think people could hear that and they think, well, okay, she's not going to focus on what she wants to do. She's going to look at what's going on with me and we're going to get the easy stuff. We're going to make those big gains first. And I think that's, but you don't have a cookie cutter approach where it's like, well, disc injury, let's do this. You know what I mean? It's looking at that person as an individual and saying, well, what does this person need the most? And what do you find? So for low hanging fruit for you, if I'm understanding, you're looking at physical activity. What else beyond physical activity would you classify as like typical low hanging fruit where you can help people?
I think this is a borderline low hanging fruit, but teaching people that stress is not just in their mind. So that psychosocial model, you don't necessarily have to solve someone's stress, because if that were the case, I would be telling everyone to quit their job and, to get rid of their kids. You can't really solve stress. But if you can validate what a patient's feeling and help them relate their stress to their pain, even that awareness can give them power over it. And Lorimer Moseley talks about this a lot, I think he uses like the black dog in the background of depression, that you might not be able to get rid of it, but once you're aware of it and you can regulate it, it makes a big difference in your quality of life. So even telling a single mom with two jobs and two kids that, hey, your back pain isn't totally coming from your stress, but some of the recalcitrance to recovery may come from your inability to rest or to downregulate or to have the time you need to take to do your exercises or come into the office. And that's okay. As long as you know that anything can change at any time. And as long as you know that you can work on these things, it's okay for you to feel stress, and you don't have to be scared of your pain, because it's a multifactorial thing that will fluctuate. And when you take that fear or that unknown away from somebody, it gives them at least a power or a knowledge, and I think it can improve their outcomes. And it's not easy, because if you say it wrong, you make it sound like the pain's in their head. And that happens a
Yeah.
lot with conventional medicine. I've had people come to me, a lot of VA patients come to me and say, oh, they think it's all in my head. I said, well, technically everything's all in your head. You hearing my voice is in your head. You seeing me in person. It's all in your brain. It's not necessarily it's not a psychological problem that you have. It's a neurological problem that you have. And it's there for a reason, but right now it's working against you, you know? So that there's a very nuance of, because that's hard education. Pain science is not a layman's topic. But if you can at least give them some power over understanding that stress is part of the water that's poured into your cup of pain that makes it overflow, then I think it takes away some of that fear of like, why do I feel like this? And why is what you're doing for that patient not working for me? You know?
That's interesting because you're getting back to communication, right? I mean,
Education,
you're
yeah.
not, because you're telling people, like, if you went out and found 1,000 people and you said, is exercise good for you? Everyone's going to be like, yeah, of course. And is stress management good for you? Yeah, of course. Do you exercise? No. Are you stressed out? Yes. So you know what's good for you, but you're not doing it. So the conventional way we're taught is like, well, that person doesn't want to get better. And it's like, well, but what you're saying, which I agree with you, if I'm understanding you correctly, is that they know, but those changes, they don't seem realistic for them for whatever reason. So you've got to get in there and make it realistic and make it okay. And it's not just in your head. It is, but it's not. And there's a physical reason, there's a neurologic reason, there's a psychological reason. There are a lot of factors. And you're talking about simplifying it, making like, let's focus on your low-hanging fruit, which could be stress, or to your point, a lot of people, it's physical activity. Let's just start there. Let's make it really simple. Do you
Even
have
lower
anything
hanging
else?
fruit,
Like, so we're
you could call it awareness, right? Even more than
okay.
stress, even more than physical activity. It's a total lack of awareness even though they are aware that those things are good, they're not aware how bad the lack of them is. Does that make sense?
Yeah.
And so the awareness is
Hmm.
the low hanging fruit, even though stress management and exercise for some people are not low hanging fruit. So if you can get someone from being totally unaware to at least a pre contemplation phase, that's the low hanging, you know, simple but not easy.
Yes. Yeah. And I think so when I talk to people about physical activity, usually the number one objection that comes out of almost everyone's mouth is I don't have time. And I'll usually say, well, how long does it take you to do 10 push-ups? Like, you don't have that kind of time? That's crazy. Your schedule is nuts. And I'll be kind of sarcastic with them, because I get it. Like, okay, I have time for 10 push-ups. Well, can you imagine if you did 10 push-ups a day for a year? The change would be huge. You'd be bored with push-ups. You'd be that good at them. Can you imagine the health changes that you would see? And then you would maybe have time for 20 push-ups, or maybe you'd have time for 10 squats and 10 push-ups. You could build on that. And a lot of people, they'll grasp that concept, and then they'll say, well, but I don't know what to do. And I'm like, okay, well,
I can't do a
I
push
think
up.
you've got
Yeah.
like a magic box. Yeah, you have a magic box in your pocket. It's not new. You literally have access to every piece of information that's ever been recorded in human history within seconds, and you're already paying for it. So if you're not doing anything, then I would say that, yeah, some programming is better than others. But if you're doing nothing, anything's better than nothing. I think what it comes down to is something that you're kind of hitting on, is that people don't, they believe that it's not, that there are barriers in the way that are preventing them from doing something, and they're not, that either it's low self-esteem or low confidence, or they don't feel like they're, like, this paralysis by analysis where they feel like if it's not perfect, whatever's going on in their head that's getting in their way. You could go, I mean, if you're working with someone like you, it's like, well, you can simplify it, right? It's like you said, simple but not easy. So the steps you're going to have to take are going to be really hard. Like, let's not lie. This is going to be challenging. To get what you want is going to be hard, but the good stuff is on the other side of hard. But I can make it simple for you to the best of your ability. And that's something I feel like maybe a role that we could play. And it sounds like it's a role that you play, is helping patients. Like, let's just make this, it's hard is inevitable. We can't do anything about that, but we can make it a simple process.
Yeah.
Do you notice any other, oh, go ahead.
I was just going to tie into something you said earlier about how it's nice to be able to transition into personal training for exercise. And that was another thing in Scott Haldeman's interview that really stuck out to me, is that, and this is going to be maybe a little controversial, and you have to remember that we have to meet patients where they're at. So, the do no harm. But he said that if patients don't have neurological symptoms, so radiating numbness, tingling, pain, muscle weakness, that, again, I can't remember if it's spinal or back pain, but back pain, let's just say, is best managed in a community setting, a community care setting. And in Africa, where it was, they had community classes, yoga classes, stretching classes, tai chi, qigong. And not everybody likes those. So here in the US, we're very spoiled. You can walk a block and find some kind of gym, some kind of anything. And other studies have validated that there's no single type or specific type of exercise that's better for spinal pain, for back pain. But exercise in general is a necessity to be able to increase your quality of life and function. And so if you can convince people or reassure people or encourage people that it doesn't matter what they do, they just have to pick something that they'll do 4 or 5 times a week. So if you're doing, back to the low-hanging fruit, if you're doing nothing and you like to walk your dog for 30 minutes 5 times a week, now suddenly you're getting close to the CDC recommendation of 150 minutes of cardio a week. Is your fitness perfect? No. But if you like to walk your dog and you can get up to 30 minutes, you're doing better than a huge percentage of people in the US. You know, if you can get someone to go to a boxing class, now that's a little bit more high impact, but a Zumba class, a yoga class, some kind of class, now you're hitting more than one of those biopsychosocial factors as well. You're hitting biological because you're getting exercise. You're hitting sociological because the people that you see frequently, whether it's at an exercise class or at your job or where, whatever, now you have a social connection, which is arguably one of the greatest predictors of longevity, is a continued social connection. And then you also have the psychological connection because anything that you do frequently, you tend to get better at. And so your self-esteem and your confidence, and if you're, also getting out of pain at the same time, now you've hit all of those factors. And going to a doctor's office, you might get a little bit of that social connection. You might get a little bit of that psychological well-being, but you're not going to get anything like you get in a community class. So if we can provide something like that, in an office setting, if we can have community events or, something, I think that's even a little bit more holistic and evidence-based than just having a patient come in 3 times a week, being in a room by themselves, having, the greatest therapy on earth. You're still not hitting the biopsychosocial model for pain, if pain and quality of life are what you want to hit. So I would say that's another huge factor of what we've already talked about, lifestyle medicine and reassurance, is if you can get somebody to that community setting. You might shoot yourself in the foot because, your patient might get better and not need you, but then they're more likely to send someone to you because you've also hit that rapport with them too.
I can imagine that in a practice like what you guys have going on, that there's people are in different stages. So someone could come in with back pain, and it could be, to them, it's the end of the world for whatever reason. It's so intense and they're scared and all these different things. And then they can see people exercising, doing personal training at different stages. And then you could point that out, like they were where you were 6 weeks ago. I mean, it's very quick. And even if they're not friends with that person, maybe just in passing, seeing those people, and knowing that, oh, they were where I was, that's where I'm going to go. That's what I wanted. Oh, that'd be so cool if I could deadlift like that, or if I could, they see someone doing something that's completely irrelevant, like a heavy bicep curl or practicing pull-ups or whatever cool personal training stuff that they like to do. And then people start to realize, because they can see it, oh my gosh, that could be me in a very short period of time, even without the direct interaction. The community aspect that you guys can build with a practice like what you have, I think that could be really valuable for a lot of people to be able to see that, rather than just going into a standard waiting room with old carpet and people in pain just sitting there not talking, that kind of stale. And then you go in a room and you sit there and you wait, and then the doctor comes in and tells you that you have degenerative disc disease and you're bone on bone, and and then you get your little treatment, and then you go home and go back and sit on your couch or whatever you have to do, and you never have that interaction. But it sounds like what you guys have is, or at least what I've seen from the pictures too, it's just it's more open. So it seems like it's more vibrant. If you made it to the end of this episode, I just want to remind you that I did lose the last 30 minutes in the editing process. I'm sorry for that. I'm going to link all of Sarah's contact info in the description. So if you are in Miami, or you're going to Miami, or you just want to connect with Sarah, you can find all of her contact info, social media, website, email. Just check the description. Thanks for listening.